Hello, hi everybody, thanks for tuning in. My name's Andrew Fuller, welcome to the I Am IMA podcast, a podcast from Newcastle University's Innovation, Methodology and Application theme. I'm joined today really kindly by Lulu Cvetkovic. Thanks very much for joining me, Lulu. Obviously we're doing this remotely, just so people who are listening know. We're currently looking at a very, very snowy February morning in 2021. There's a lot of snow here at the seaside. There's a lot of snow inland as well. But yeah, Lulu's joining me. She's a quality assurance manager who works at Newcastle University, has done for a little while. Hi, how are you, Lulu? How are you doing?
Good morning. I'm really good this morning. So thanks very much indeed for inviting me to join you and speak.
It's my pleasure. Thanks very much for agreeing to it, for signing up for it. I guess we've never actually met in person, but we know kind of similar people. We work in similar fields. I know your name's come up across my emails in the past, talking about QA, quality assurance. But you work. So how long have you been working at Newcastle? What you're doing? I noticed you used to work for the NICR, and then that no longer exists now, technically speaking, I guess. So could you what is it roughly, just in like a couple of sentences? What is it? How long you've been working at Newcastle? What is it that your job title involves, I guess?
So this year it'll be 10 years since I joined Newcastle University.
Oh, good.
So like you said, originally when I joined, it was NICR, as people probably still know it, Northern Institute for Cancer Research.
Yeah.
And then following a major restructuring in November 2019, we're now the Newcastle University Centre for Cancer. So we changed from NICR to NUCC.
Okay. So you're still tied with the NUCC?
Yes.
Yeah. Okay.
Yeah. So physically, I sit in the Paul O'Gorman building, and my remit is the Paul O'Gorman building and also the Herschel building, floors 5 and 6, where we also have researchers that work on childhood cancers. So, like you said, Andrew, my role is quality assurance manager. So primarily, I'm funded by ECMC, Experimental Cancer Medicine Centre. So they fund me to work on clinical trial studies, which are run by Professor Gareth Veal. So I don't know whether you know Gareth.
Only by name. I've never met him, I don't think. Yeah.
So Gareth runs a number of adult and paediatric clinical trial studies, and a really important component of that is the quality assurance, which is my role comes in. So I'm kind of responsible for making sure that we've got all those processes in place to make sure that we comply with all the applicable regulations. So in the case of clinical trials, it's GCP, which you may have heard of, Good Clinical Practice.
Yeah.
So that applies to medical devices and CTIMPs, so it's medicines that are being tested as well. And obviously for us, like I say, we're testing them on paediatric patients as well as adult patients as well. So it's really important, for example, when we send reports out to sponsors, that all the data that is in those reports, that it's been checked, that it's been verified, that someone's checked the reports from start to finish to make sure that everything that's in that report matches what's in the raw data, and that it's all factually correct as well. So that's kind of my role really, as well as kind of approving all the SOPs, auditing the labs, and just kind of being available to help anyone who's got any queries on GCP, and also the HTA, the Human Tissue Act.
Yes, I was going to say,
in terms of the rest of my role, regarding the Paul O'Gorman and the Herschel buildings, I'm also the quality assurance manager within that area for the HTA, the Human Tissue Act.
Okay.
That also takes up a lot of time as well.
So does that mean you've got a fairly acute tie-in with the biobanks and things like that as well? Do you have much work with them as well?
Absolutely. So I work very closely with Amy Peasland, who runs a central biobank, and also Emma Rain, who runs a really successful bioresource and who was the biobank manager for Newcastle Biobank. So in terms of HTA and biobanking, they really are my go-to people for absolutely everything. I think it's really important to kind of surround yourself with people who know more about things than you do, and have them there.
Absolutely.
It's really useful contacts. So they've been absolutely invaluable.
No, it's really good.
For people.
No, I totally agree with you there. Like if you don't know, we've got to find somebody who does, and the more people we can ask to help us out, the better. I think the better it'll be. So that's really interesting, because I've been wanting to talk to somebody like yourself, because it's common for me. So I always come to these podcast interviews from my background, which is pretty much straight through academic research. So from graduate to postgrad, being a technician to being what I am now. So I've always joked with people, I've not been outside of a university since 2004, which is a bit worrying now in 2021, but there you go. But obviously what I ended up doing, or what you end up doing, although we're sort of one building away from each other, is it could be more different. Like your view on things is a lot different. So I want to take you right back to, in the way, we won't ask for dates, but when you were doing your undergraduate, whereabouts did you study? Are you up in the Northeast for good? Are you native to the Northeast, I should say, or did you move up here for undergrad?
So no, I'm not native to the Northeast. My family are from Serbia. I was brought up.
Oh wow, cool.
Yeah, so English is my second language. I was brought up speaking Serbian. Didn't learn English till I went to school, which was very traumatic, as you can
Wow,
see.
yeah.
I did my.
Sorry to interrupt. Is it true what they say? Is English really hard to learn if you don't learn it as your primary language? That's what I've heard. That's the route that it's like a very difficult language to learn as a second language. Is that true? Is it just a complete sidetrack?
I can imagine that it would be. I mean, for me, because I was quite young, I was sort of like really thrown in the deep end. I was kind of like immersed in a situation where I had to learn English. I had no choice. And I think when you're that age and you're immersed in that situation, you pick it up a lot quicker because you don't question things. So in languages, you have like regular verbs and then you have irregular verbs that don't follow the same pattern. And people can quite often get hung up on, but why? And it's kind of like, well, you just have to accept that's how it is. So in England, for example, you might say something like, I ride a bike. In Serbia, you would say, I drive a bike. They just use a different verb.
Right.
You would say, I make an exam rather than I take an exam. And it's not kind of one's right and one's wrong.
No, it doesn't make any sense, right?
It's England, and that's the verb that they use in different countries. And I think a lot of people get very hung up on, but why do they do that? Why do they say it that way? And the answer is they just do.
Yeah, there's no logic to it a lot of time, is there? I think that's what people's major complaint about when they learn English, is there's absolutely no logic to it, and words that look exactly the same and sound exactly the same are spelled completely differently. I'm just having just to keep people behind, I'm acutely aware of this. I'm trying to teach a 4-year-old how to read and write in lockdown, which is a lot of fun, and it's so that was just on my mind. Sorry. So yeah, you're not from the Northeast. We're from Serbia originally. Okay, English second language. We'll pick back up there. So when did you? Where do we go from there?
Okay, so I went to Sunderland University and I did a degree in physiology. So my mum's a nurse, and from a young age, I was always kind of interested in the human body and how it works and that kind of thing. So I was a mature student. I was working full time, did A levels, and then I went to university when I was 25.
Okay.
Really enjoyed my time in Sunderland, made lots of great friends, fantastic course, fantastic lecturers. And then after I'd done my undergraduate degree, I went to Leicester. So I moved back home to Coventry, lived with my parents, went to Leicester for a year, and I did a master's in molecular pathology and toxicology. So it did really well for me, because after learning about how the human body works under normal physiological circumstances, it was really interesting to then kind of learn about what happens to the body in disease states.
Excellent. Yeah, that sounds really, really interesting. So I want to give a quick shout out to Leicester, because my mother, who is a massive fan of this podcast, my biggest fan on here, also went to Leicester University, so it produces some excellent quality graduates, clearly. So how long was your master's it was a master's, right? How long was your master's at Leicester? Is it
I
a couple of years?
Full time.
Okay.
So it was just 1 year, so it was 6 months of it was taught in Leicester, and then the last 6 months of it I had to do a placement. So I actually came to the RVI and I was working in pathology with Dr. John Anderson, and I did there.
Excellent. So you kind of had, for whatever reason, we've had a couple of ties to the Northeast. So after the masters, was it a fairly easy transition to stay up in Newcastle? Was that the jump back up to Newcastle? Because you didn't come straight to university after that. Where did you start working after you did your masters?
So after I did my masters, I did move back up to Newcastle. So at that point, I had my own house. I was living with a partner. So my life was kind of in Newcastle.
Right.
Although I'm not a native from the Northeast, I absolutely love the Northeast. Brilliant location. I love the fact that we're close to the sea, which obviously in Coventry and in Serbia, there's no sea. We've got Scotland not far away. Then we've got the mountains and the Lake District.
It's ideal, isn't it?
So it's brilliant. I absolutely love it here. And I always felt very, very settled and at home here. So I moved back up to Newcastle after I did my masters. I went to lots of different scientific recruitment agencies and gave them my CV. And I knew at that point that I really wanted a job in a pharmaceutical company.
Okay.
It took a little while, but eventually I did get a temporary position for a pharmaceutical company called, at the time it was Sanofi Syntholabo, who were based up in Alnwick.
Okay. Yes. Yep.
So I'm sure you've heard of those.
Yeah.
So I got a job at Sanofi, which originally was temporary, and then it did get made permanent. So I was working in the formulation laboratory, sometimes known as the pharmacy or the dispensary, very much doing preclinical work.
Okay.
The department that I was in was drug safety evaluation. So I know that you've had Phil Berry on a podcast here. So
Yes,
I was
he
in
was.
the same department as Phil Berry. Worked in different labs, but Pharma is very kind of structured. So we all had to go to coffee at the same time every day. We all had to sit on the table with our departments and pretty much eat the same thing at the same time. So I got to know Phil very, very well. And it was actually Phil who, he left Sanofi 2 years before me to come to Newcastle University. And it was Phil who told me about the QA manager's role through a mutual friend, and sort of thought it might be a good thing for me to apply for, and I did.
Excellent. That's amazing. That's we had Phil on the episode before this one. I always found it really interesting because I've never worked for yeah, he is. I've never worked for a big pharmaceutical company. I've worked for a very small one. I did a placement year in my undergrad, and I worked for a very, very small pharmaceutical company. I liked it, but it's very, very different to working in academia. I found that was a big shift for me from going from being a student to being working for a pharmaceutical company. How did you find it? Because obviously you went from being a master's student to wanting to work in pharmaceuticals, and then from being that really regulated kind of, you have to follow a certain pattern, even to, by the sounds of things, even down to taking coffee breaks and lunch breaks with people at the same time, and following, a lunch SOP. I don't know who wrote that one and who reviews it. But going from that, to try and give that sense of regulation and control in an academic scenario, how's the change from one to the other? Was it difficult coming back into academia, or was it?
It was. I mean, I was in industry for almost 10 years as well, so I was there for quite a long time, and obviously they have very, very set ways of doing things. When I first started at Sanofi, obviously it was a French company, so we had kind of an hour of French lessons every week. There was lots of...
Oh wow, really?
Yeah, it was brilliant.
Oh, that's cool.
Yeah. There was a group of us, 4 of us, who were all at about the same level, and the teacher who came in on site, she was actually a French lady, and so she'd get us to like read paragraphs in French and then answer questions on it, and quite often she'd get us to just have general conversations between ourselves in French, which was really funny because we all understood each other, but she had no idea what we were. But I mean, it was really, really good fun. And there were lots of trips to France to kind of meet our counterparts, so people who did the same jobs in France that we were doing in Alnwick.
Whereabouts in France was it? Sorry to interrupt you. Whereabouts in France was it?
So I spent some time in Montpellier, down in the south of France.
Lovely.
I also spent a lot of time in kind of like the Paris area. So they had about 3 or 4 different sites that were sort of in and around Paris. So quite often I would sort of get the first flight to Paris in the morning at about 6:30, and then I would get to France at about 6:40, because obviously the time difference.
Yes.
I'd sort of spend the day in meetings or whatever, and then just fly back the same night. So that was quite a common thing.
I mean, that's a hell of a commute, I'll tell you.
It is.
A bit different to life today.
Very different, yeah. But I made lots of great friends from the States, from France, who I still keep in touch with now. So yeah, it was all good. I think when I came from industry to academia, it was like a massive shock to the system. I don't really know how else to describe it. I sort of remember my interview at Newcastle University, and Alan Boddy, who interviewed me at the time, kind of said, so imagine that you're sort of auditing someone in a lab and they're constantly doing something wrong. What would you do? And I said, well, I'd speak to them about what they were doing wrong and let them know what they should be doing. And he said, but what if they still kept doing it? And I was like, okay, so at that point, I'd maybe sort of think there's a training issue. They need refresher training. They need more training. And he was like, but what if you gave them training and they were still doing it wrong? Then what would you do? And I was like, well, at that point, I'd probably speak to the line manager and, sort of share my concerns with them. And Alan was like, and then what would you do if they were still doing it? And I was like, well, I'd probably pull them out of the lab and say, you can't work in the lab anymore. And Alan said, well, that's the difference between industry and academia. He said, in industry where you come from, that's absolutely what would happen. But in academia, you just can't do that.
Right. Right. So I mean, let's just carry that. So what do you do about how far can you get down that road before, if there's people doing constantly doing it wrong? It must be so hard to, because academia is like this massive amorphous blob of people doing everything they want, right? That's the joys of being in academia is, if you get budget and you've got an idea, feel free, go ahead and chase it within reason. But to try and impose a really strict, obviously necessarily so, but like a strict framework onto that, like how do you wrangle people to do that? I don't envy it. It must be so.
It is really hard. And I mean, we have like really good trainings all documented. Obviously for GCP, it has to be so that we can prove that that individual was trained. We have SOPs that staff are trained on. SOPs are kind of certified and laminated, and they're placed around the lab and next to the equipment that they relate to, so that people have got them there for reference. Ultimately, I think at the end of the day, the responsibility lies with that individual's line manager and that person's PI. If it's a student that we've got in the lab, obviously they've paid a lot of money to do that course, they've paid to be in the lab, so we can't just then kind of pull them out of the lab. So maybe we'd have to try and find a more desk-based project for them to do, maybe analysing data perhaps, or something like that, so that they're still getting something out of it for them, but liability in the lab to people around them. So it is really hard.
Yeah, it is. I mean, I mean, I've never worked directly on a clinical trial myself. I've been because I work in the flow cytometry core facility. I know there are people doing ongoing clinical trial work, either preclinical or in the middle of a clinical trial, using some of our instrumentation. And I kind of have a vague awareness of how much effort has to go into the SOPs, and we put a lot of effort into ours, which is mainly we started doing when Andy Philby came on board. But I know it's a massive task to kind of make sure that not only is everything documented, but everybody's read it, everybody's trained, and everybody agrees to it, and then any changes have to go through everybody and through yourself, and it's a lot of work ahead of time before you can actually start any wet lab work, which is always a little bit opposite to what people actually feel like I want to do in academia. Like me in an academic lab, I was always more about, well, give me a pipette and a job and I'll go and do that, and I'll show me the paperwork later, I'll figure it out, but I'll just do it the way I think is best, which is absolutely not what you need to do in a clinical trial. You need to know everything before you start and then start. Because I don't know if you, the guys over in the Centre for Life, on the top floor of the Centre for Life, there's a cellular therapies facility up there. Yeah, so CTF. So we've done a clinical trial with them before, and that's kind of like my only limited experience of it. But I guess what I wanted to ask was, like, coming from me personally, going from a place of pure research or doing the facilities work, and then having to take on this clinical trials work for the CTF, it felt very different to me. It didn't feel like the kind of science I was doing normally. And I often felt like I was kind of running to catch up to this group of people that do this for a living, right? So they're used to handling the SOPs. They've got the framework in their head, and they know how they're supposed to follow it. And I just wasn't there. I felt like I was, there was very conscious that there was lots of things that I needed to do and I had to do them right, and so on and so forth. How do you think, what do you do for new people coming into the lab and they're going to join a clinical trial, they're going to join the clinical trials team? How do you get them up to speed if they're coming from an academic background or like a completely new graduate? What kind of training program do you have to put in place to kind of get people up to speed?
So we've got our own kind of in-house, we call it GCLP training that I do. So it stands for Good Clinical Laboratory Practice. Right. And that kind of talks about GCP at a very high level initially. And then the second half of that training is me kind of talking about specifically how we meet all those criteria within what was the NICR, now the NUCC. So that's kind of like one of the first steps. Then obviously they all have to have GCP training, they all have to have Human Tissue Act training, they also have to have training on the various different bits of equipment that they're going to be using. They have to be trained on how to calibrate their pipettes, for example. So in the Paul O'Gorman building, we calibrate our pipettes every 3 months. Just as a comparison, when I was in industry, we used to calibrate pipettes every week.
Yeah, wow.
So people who complain about doing it every
3 months, yeah, right, I bet.
So there is a lot of training. They're always kind of buddied up with someone. within the Paul O'Gorman building, it's predominantly just one group, Gareth Veal's group, who work on the clinical trials. So generally we all kind of like sit in one area. We're very, very close. We all work very closely together. I think if there are any problems with new starters, it's very easy to kind of pick that up and just kind of like help them before they maybe feel too overwhelmed or too lost, which I can imagine it would be really, really easy to feel like that. So we are a very kind of helpful, supportive group.
Yeah, that's really good. Because do you ever get approached by other areas, other groups in the university who want to start or want to get involved in a clinical trials work? And do you ever have input on how they can get going on their groups as well, or is it? I know it's mainly in Gareth's group, but do you ever get approached to kind of help out other people's as well, or?
Yeah, so I have been approached. I was approached by the mitochondrial group a couple of years ago with Professor Sir Doug Turnbull. He approached me as well. So I kind of went and gave them a presentation that was just kind of about how within the Paul O'Gorman building and within my group, how we comply with the Human Tissue Act, and also how we comply with the GCP regulations and the processes that we have in place. And then I did spend quite a bit of time, myself and my colleague Julie Errington, with members of that group, kind of going through various different sections of GCP and kind of sharing our documentation and paperwork that we already have in place, our SOPs, and kind of saying, if any of this is useful to you, don't reinvent the wheel, just use it, modify it, amend it, and just kind of do it that way.
Yeah, that must be a massive relief if you've got somebody with your experience coming up to you and saying, yeah, look, we've done this. This is how you do it. This is how we train. This is how our documents look.
Yeah.
This is how yours should look as well. Follow this, follow this pattern, and we can get to the same level. That must be. I mean, I know that would be certainly if we want to do any clinical trials. I know who I'm phoning up. So.
Thank you very much. But the mitochondrial group were great to work with, and we also, got a lot out of that from working with them as well. And one of the good things about that from our perspective was that, when you're kind of talking about your processes to other people, they can question, well, why do you do this? Or why do you do that? So by explaining the reasons why, you're kind of reaffirming it to yourself as well. And sometimes you might stop and think, well, yes, actually we do that, but maybe we could do it better, or maybe we could do it differently. So it's really, really worthwhile for us as well, because obviously with things like GCP and quality, it's always changing. They're always raising the bar. So just when you think that you've got there, they kind of raise it a little bit higher, and you have to tighten up your procedures as well.
Yeah, okay, yeah. I mean, I know what you mean. It's even on any level. I think if you take anything that you spend a lot of time on and have to teach it to somebody completely new or share it with somebody completely new, it always does change how you think about it a little bit, because you can't. It's never a one size fits all. You're going to have to modify it a little bit to fit somebody, and where you can change and where you can't change, knowing you don't necessarily know where that is unless you start trying to train people. Certainly I felt like that in the past, so that's really interesting. So I'm going to try and steer the topic of conversation back to the IMA, because I know a lot of what we've spoken about so far, kind of transitioning into academia, I think there are a lot of people that do that at university. I know we get a lot of people from all over doing different industries and coming to work into academia. And I'm always interested in finding out how those people found it. Invariably, though, most people say it's a big shock to the system, but once you get used to it, you get used to it. It's fine. I do often wonder if it's a shock to the system going the other way. I think maybe it's a bigger shock going the other way, probably a worse shock going from academia into industry.
Massive shock going from academia to industry. I mean, it really would. I think things that, we sort of take for granted in academia is very much kind of like the flexibility. So, I could start later in the day and finish later in the day. I might choose to kind of change my working hours slightly.
Yeah.
Whereas in industry, we had kind of flexi time, but you had to be on site at 9:30, and the earliest you could leave was 3:30.
Yeah.
We weren't allowed to check emails from home. We weren't allowed to take anything home. So no documents, nothing, everything had to stay at work. We had to have like clear desk policies. So everything had to go into like locked cabinets and things in the evening before we went home. I mean, we had training on things like you should never just walk away from your PC and leave it open, leave it unlocked, because somebody could come on and send emails from your account, or they could go through your documents or anything, particularly when we changed from a pharmaceutical company to a contract research organisation. So in the last 12 months that I was in industry, we changed from Sanofi Aventis, who decided that they didn't want the Annex site anymore. to Covance. So Covance took us over, and because Covance have so many compounds that they're developing for so many different people, we had loads of people on site from different companies on all the time. So we had to have training on, for example, how to deal with clients who were from the Far East. So things like when you have the Japanese businessmen on site, you have to line up in order of importance. When they give you a business card, you have to look at it, and then you have to kind of read it line by line. And it was just teaching you about what people from other cultures find respectful, and things like you should never put on your out of office that you're away on holiday. You should always put that you're just away from work, for example, and when you'll be back, that kind of thing.
That's an interesting one. I've never heard of that. I've seen all variety of out of office replies from university ones. Yeah, I think it would be a massive shock if you came back to it. If you went one way to the other. I don't know how. I've only been in industry for a very short time. I'm not sure. I think I'm too set in my ways now. I mean, I won't say how old I am, but yeah, I think I've been there too long. So yeah, I like the flexibility. You do kind of. I mean, like anything, I think you take the flexibility for granted if you stay in it for long enough. But yeah, like I think people can be made slightly more aware of how flexible we've got it to kind of take advantage of it. It's definitely good. But when it comes to because this is obviously the I Am IMA, I just wanted to try and put what you do and what the other people that I've spoken to in the IMA theme into context, because I think it's really, really interesting for me that somebody like yourself works at Newcastle University, same as we all do. But what you do is acutely different to what a majority of other people do. And I think it's a really key point. If there are people in the IMA theme, postdocs and PhD students and PIs, lots of P's there, I realise, postdocs, PhD students, PIs, all those different people could certainly see to gain a lot of benefit from taking a little bit of an interest in the things that you do on a day-to-day basis. And I just wondered, like, do you think do you ever wish that there's like a subset of things that people knew off the top of their head or knew ahead of time before they approached you to get some clinical trials work? Do you wish that those questions, those same sort of 3 questions you get asked off the bat, I'm thinking about doing a clinical trial, what do I do? Or do you get like those top level questions, or do you think there's capacity within the IMA to kind of maybe suggest people start taking a bit more of an interest in this, in what you do and how that affects them? And I guess 2 parts to that question is, do you think there's definitely an interest for that? Do you think that's something that would be useful? And of those kind of top tier questions that you get asked on a weekly basis, I imagine, what do you wish people knew before they came and spoke to you?
I guess I wish that maybe people had a little bit more awareness of kind of quality and regulations. I think a lot of people kind of assume that what they're doing must be GCP. Or there's the really common misconception actually is GLP, which stands for good laboratory practice.
Yeah.
So when I worked in industry, it was preclinical work that we did, which was GLP. So GLP is always specific to preclinical work.
Okay.
But because of the name good laboratory practice, there is this misconception that it's just people that work in any lab who do what they do well. So they are working in a laboratory and their practices are good. And actually it doesn't mean that at all. It's completely different. So a lot of people think that they're working to GLP, but it really isn't that at all. And I think the science and the quality really go together kind of hand in hand. And
for sure,
the science is extremely important. It's, for the university, it's the bread and butter, it's what we do. But there does need to be a little bit more focus, I think, on the quality. And one thing that, I sort of say to people within the NICR quite frequently is, if people who have done the PhD, and I don't have a PhD myself, so I've got nothing but respect and admiration for anyone who's achieved that level of education.
Same.
If you've got your PhD, somebody should be able to read your PhD. They should be able to do all the experiments that you've done just from reading it. So not you telling them, but just from like looking at the documentation, and they should be able to get the same results that you got. It should be reproducible. And if not, then why not? And is it really kind of as credible as you might think it is. And that's pretty much what GCP is really. It's just about making sure that everything that we do, that it is credible, that it is accurate, and that if somebody else were to do exactly the same experiments, that they would get the same results. So I mean, basically with GCP, everything has to be documented, as you know. So as far as the MHRA, the regulatory inspectors are concerned, if it's not documented, it didn't happen.
Yeah.
You can't ever kind of stand in front of an MHRA inspector and say, well, I wasn't here then, that was before my time, so-and-so did that, and they're not here today. You should always be able to look at those records and reconstruct exactly what happened. So who did what, when, using what equipment, for example, on which dates.
Yeah.
So, that's the important of that record keeping in GCP.
I think that you could, if people applied even a small percentage of that kind of really fastidious record keeping to day-to-day lab work, you'd be amazed. They'd be amazed at how much easier it is to do lots of different things. Like, thing that made me acutely aware, like, we didn't have very good standard operating procedures prior to Andy Philby starting. And one thing he made us do, which was painful for the longest time, but it's less painful now, is to write very, very, very detailed SOPs and risk assessments all in one document into something that we call a SOPRA, SOP, standard operating procedure and risk assessment, all one together. And we put a load of effort into them, and they're very, very detailed. But because we have those in place now, when people come and talk to us and ask us, well, where do I start? We have a document that we can send them and say, look, this is a pictorial baby steps, walk you through bit by bit, what buttons to click and everything you need to do. Follow this and you will be using the instruments in the same way we are. And we now, it's also not just do we get people up to speed faster, but it's a wonderful resource, because if you put all that effort in the front end and get those documents out there and make sure people read them, when people are doing stuff wrong and they say, well, you never told me how to do it, you go, well, I did, because I've got a document that you signed. Definitely. And you said you did know how to do it. So this isn't on me, this is on you. And you can just go, look, reread the document and we'll all be back on the same page. And I think if people, academics and people in the IMA team, if we put a little bit more effort into that and a little bit more awareness of the positive impact, not just the negative, oh, this is going to take me ages, but the positive impact of what that can have on students coming into your lab or other academics coming into your lab, you'd be surprised at how fast people get better, and how much more repeatable stuff is. Like you said, like if everybody had quality assurance on their PhD thesis, then every new PhD thesis that was building on an old one would be starting at a much higher point. You wouldn't be, as I'm sure PhD students listening to this might be aware, you wouldn't be repeating work that other people have done to see if it still works, because of course it works. There's all the documentation that says it does. So I really hope that we can get something like this. I think there's potential. I mean, I don't know how interested you are. I don't know, the IMA is going to be doing, we are doing special interest groups. So we're going to be doing SIGs. I know Phil's going to be involved in one. I'm personally involved in a few. I think if we can put an aspect of quality assurance into the SIGs, or even have a separate SIG for it, and just get people to be a little bit more aware of it. It's not just about getting into the lab and getting your hands wet. If you could just pre-prepare yourself a little bit, you're going to make your life easier further down the road. And then when you do want to transition into doing a clinical trial, well, you've done 90% of the work, and all you've got to do is 10% more.
Exactly.
So I think that's a really valuable thing that you can bring to people.
And I think as well, Andrew, sorry to interrupt, that
no, please.
The SOPs that you're just sort of talking about there, they're also there to protect you and to protect the patients on the clinical trials. So yes, it protects you, because if anything were to go wrong on a clinical trial, you've got that SOP there to say, well, this is the SOP that was approved by management that I was following. And obviously it's protecting the patients, because they know that when you're kind of analysing their samples or testing the drug or whatever it is that you're doing, that you've got proper procedures in place, and that things aren't going to go wrong because you've done something incorrectly. So, it's good all round for everybody. Yeah,
totally. And if people do end up doing their training with us at Newcastle and then going into the wider world, I think, and they don't work in a university, if they don't work in academia, I think the more experience you can have saying that you've done high level SOPs or high level quality control in the lab that you've worked in previously, the better standing you'll be working in an industry lab, because it's a heck of a lot more regulated than people think it is.
Definitely. There's lots of audits, there's lots of MHRA inspections.
Yeah, absolutely. I mean, I have friends who work in big pharmaceutical companies and used to work. I have a friend who used to work for Covance up in the Central Belt in Scotland, now works for PPD, and loads of people who work for GSK and Pfizer and all over the country. And the amount of regulation they have to do compared to the amount of regulation that I have to do is it's two worlds apart. So what I'm basically saying, trying to get out to people listening, is that, you know, that I would be interested in getting a voice like yours heard more widely, certainly within our theme members, so that people can start thinking about this sort of stuff and taking it on board, because I think it's so massively impactful on day-to-day work, and everything that you've spoken about just makes that really, really obvious, that it would be of huge benefit to people if they just started doing a little bit more of it. And it's not necessarily, okay, everybody down tools for 3 months whilst we all write SOPs. It's not that, but it's maybe, okay, maybe we start reviewing our SOPs once a year. Just as an extra aside to that, like the amount of risk assessments I get sent through, we started asking for risk assessments to be shown to us prior to people booking the instrumentation. The amount of times I had people say, "What's the risk assessment?" was shocking. Yeah. I mean, if people are listening, I don't know, you know, if you don't know what the biogosh is at Newcastle University, if I have to explain that to you, then I'm not going to let you anywhere near my kit or in my lab, because you should know that before you started in the lab. And if you didn't, it's not necessarily the individual student's fault, but they should be given training up front so that they know what the risk. It's not just signing up at the last page and not ever reading it. That's no good either. Okay, you've got to know what's in it. It can't be dated from 15 years ago. You know, it's got to have the right names on it, the right dates, and it's got to be reviewed and signed. And there are people who have good lab managers, good technicians that stay on top of that for them. But it's no good if everybody doesn't buy in. You can't just have one good person doing it. Anyway, that's my rant over. So I mean, I'll start wrapping this up. But yeah, I think it would be really useful if we can get some of this, more of this kind of QA thought processes to a larger group of academics. I think that'd be really, really fascinating. So I might come back to you with that, as if you're interested in joining some of our things. That'd be really, really useful. But yeah, so thanks ever so much. I just want to do a couple of announcements just at the end of the podcast. People are still listening. We've got some IMA external speaker and internal speaker meetings coming up. So we've got Wednesday, 3rd of March, 10 to 11 a.m. A Zoom meeting with Dr. Marie Phelan, from the University of Liverpool, and she's going to be talking about introduction to NMR metabolomics for cardiovascular research. We've got Dr. Mary Neal, Research Associate in vivo imaging. So that's as an internal talk on the 24th of March at the same time, 10 to 11, looking at non-invasive lung ventilation and imaging in COPD and asthmas using fluorine MRI. Sorry, that was a weird mix of letters I couldn't say. Fluorine MRI, which will be really, really interesting as well, especially with the, I imagine that's getting a lot of buzz at the moment with the impact of coronavirus and COVID on patients' lung tissues. If they're trying to think out innovative ways to image lungs, then the more the better, really, especially in people with COPD and asthmas. So there's a couple of really interesting talks that we've got coming up. I'd like to point people to our research.ncl.ac.uk page /IMA for all other details. And last of all, I'd like to thank you very much, Lulu, for giving me a bit of time on a wintry Thursday, sorry.
Thank you indeed. Really
thanks very much, and I look forward to speaking to you again soon. But otherwise, take care. Thanks for that was a really good chat. Thank you. Bye bye.